All right. Thank you, Sydney. Good morning, everybody.
Good morning. Good
I
morning.
want to thank you all for joining me on this lovely rainy day in my area. All right. So today I'm going to take you through pretty much, is it Medicare fraud or is it something else? And I deal with this on a daily basis because sometimes I never know if it's fraud or not. So pretty much what I have to determine is, was it fraud? So here's the definitions of what fraud are. And what is this here? So, is it fraud? Of course, and fraud is defined by the intentional act of deception, misrepresentation, or concealment committed in order to gain something of value. Also, the definition of abuse is defined as incidents or practices of providers that are inconsistent with accepted sound medical, business, or physical practices. So I deal with both of these on a daily basis. Sometimes it is billing issues, which sometimes I consider abuse, or, if they keep doing the same abuse after they have been educated by Medicare on how to bill things, then it can actually turn into fraud. So there's a lot of difference between fraud and abuse, and I also deal with a lot of billing errors on a daily basis. So, okay, why is it not going? Sorry. So, of course, fraud is the intentional component that separates, the hardworking and honest providers from the fraudsters. Because there's a lot of good doctors out there that are doing what they're supposed to. There's some out there that's not. So, of course, abuse generally involves an innocent mistake by the physician or the coding staff who are not aware of, how they're supposed to bill things. And it's not intentional. For example, I do a lot of the QMB where providers they bill QMBs and for the cost sharing when they're not supposed to. And a lot of that is lack of education. So I have to educate the doctors and their billing companies on, telling them that they are not supposed to bill QMBs. They're actually violating a federal law when they do that. That's not necessarily intentional. Now, if I keep getting the same doctor over and over again after I have told them that they're not supposed to bill QMBs, I usually turn it into fraud because then that becomes intentional. So here's some situations that I have dealt with that are either errors or may not be fraud at all. And most of those are a beneficiary gets a bill from a provider that they haven't seen. For example, most of those providers are like the pathologist or anesthesiologist or radiologist, things like that. I had to explain to one lady one day when she fell and broke her hip that the person that read her X-ray was a radiologist because she didn't know who that was. So just explaining to some of the beneficiaries what some of the doctors do. Of course, they won't see them because they're behind the scenes. A lot of beneficiaries doesn't realize that if a doctor, draws blood, that blood actually has to go to a laboratory unless the doctor has, a lab in their office, which most of the time they don't. That has to go to a separate laboratory to be analyzed. And they don't realize that they could get a bill from that. Another thing that, where an employee, a beneficiary didn't actually see the physician. They saw like the nurse practitioner or something like that. Most of the time those claims will go through the physician because they're billing off the physician's medical code because Medicare gives them a certain number, their provider number. So they may be billing off that provider number. There's nothing wrong with that. Another issue, always, they miskey things, they miscode things like that are not necessarily fraud. Sometimes they put in the wrong Social Security numbers on people where they've transposed numbers, things like that. I've seen all that happen before. So just going in and get it corrected. The big thing is if they're willing to get it corrected. That's the really big thing. Another thing that I see that is not really fraud is hospital inpatient bills, where a lot of people do not realize that there is a deductible that they have to pay before Medicare will start picking up that 80%. Some of them didn't realize that there is a Part A deductible. Does anybody know what that Part A deductible is?
$1,316.
Okay, yay!
Benefit period.
Yeah, per benefit period. That's another thing that a lot of beneficiaries don't realize, that it's per benefit period. So, does anybody know how long a benefit period is?
60 days from the time you get discharged.
That's right. It starts a new benefit period. So if they go back into the hospital during that 60 days that they got out, they are still in that same benefit period. So they don't actually have to pay that new deductible. But if they go back into the hospital after that 60 days, they will have to pay that deductible. Does anybody have any questions about that? Because that kind of gets confusing sometimes. And another thing, some people think that the benefit periods like if it's December 31st or whatever, that the new benefits period starts January 1st. It doesn't go by calendar days. By calendar years. So if they went into the hospital on December 15th and they don't get out till January 31st or 30th, then that's still the same benefit period. Everybody understand that?
Yes.
Okay. Just making sure. So some types of billing fraud and abuse that I have seen, and I've seen a lot. Of course, I've seen where patients being billed for the wrong treatment. Double billing. I've seen that. I've seen double billing a lot. Ordering unnecessary tests or services. I give this example. I had one referral where a gentleman, he went to the ER for a cat bite, and they wanted to give him a chest X-ray. Yeah, thought that was funny. Let's see, some false claims, billing for services or procedures that weren't provided. I just recently got one where a gentleman, he never saw this doctor, and it's at all. Upcoding. I get a lot of upcoding, or where they make the patient sicker than what they are. If I could ask somebody to please mute your phone, I'd really appreciate it, because I'm getting a lot of background noise.
I think they think you are on it right now. They said it's just Joanna.
Other things that I have seen, unbundling. Most of this is where labs will unbundle some of their procedures that they do. Balance billing, I see a lot of that. I just got a call yesterday where a QMB is getting balance bill from a doctor. Now, this one here, this kickbacks, it's very hard to prove that unless you actually know that the doctor's actually getting kickbacks from, and they can get kickbacks from anybody, like pharmaceutical companies, labs, anything where doctors can get kickbacks for sending patients to that certain facility. Another thing that I've seen, waiving copays and deductibles. That contract that the physician signs with Medicare, it states that they have to bill patients for the copays and deductibles. And another thing that I really see, especially right before open enrollment, is Advantage Plan agent marketing violations. And I'm not going to go over a lot of those today because there's a lot of violations. I usually go over a lot of those during our update training right before open enrollment. And usually I give out a list of those during my when we do update training, just to make you all aware. So what to do if a beneficiary has a billing issue? So what do you all think? My first thing is when I get a referral is I contact the doctor's office. I ask the beneficiary most of the time when I get them is the beneficiary has already tried to contact their provider and it hasn't went anywhere. So usually after I try to encourage them to, if they haven't called their doctor provider, because most of the time they have a better relationship with that doctor than I do. So I highly try to encourage them to call their doctor first. And then if that doesn't work, then I usually step in and try. So at least, try to ask them to call the provider first. If that doesn't resolve the issue, then what I encourage you all to do is if you've got the beneficiary there with you, get the release of information sign, which I attached with my PowerPoint. Any copies of medical bills, if they've got a Medicare summary notice or anything like that, explanation of benefits to go along with it, that's very helpful. Anything that you can give over to me that will help me build my case or help me. Yeah, Sharon, you got your hand raised.
Yeah, Lonnie, is that the form you need? If I send you somebody, go ahead and get them to sign that form.
Yeah, that release of information, yes. That is the form because that protects me from HIPAA, and it's pretty much they're giving me permission to work on their case.
Yeah,
and I really have to have that. Yeah, I can't go forward with a case.
Briefly. Yeah. And it was like, oh, I lost that form. So anyway, yeah, great.
Okay.
Thanks.
Yeah. Yeah, I can't do anything without that release. I can't pass it on because, without their permission to pass it on to anybody, I can't even refer it to OIG without their permission. So I highly encourage you, please, if you're there talking to somebody, you don't have it handy, if you could shoot me an email, I can email you the form if you don't have it with you or, anything like that. I can fax it to you, whatever you need me to do. You've got it on email now, so, please save it, keep it in a safe place. I don't know, you can maybe save it on your flash drive that Sydney has given you, that some of you have, those flash drives.
Mm-hmm.
If you could save it on that, that'd be good. Highly encourage that. So just get as much information as you can. Another thing that I like to get from beneficiaries, if is like a timeline. When they've talked to somebody, who they talked to, that sort of thing. That kind of helps me also. Because then I can pass that on to OIG and say, look, the beneficiary, attempted, this many times. Here's their notes, or here's their timeline. I've done this. So it kind of helps build the case, if that makes sense. So I can send it, on to OIG. So does anybody have any questions about?
You also sent us a fraud abuse referral form. Do you need that filled out too?
Well, if you can, that'd be good. If you have them, I really appreciate it. And I need that filled out to as much information as you can get. Because if I have to call Medicare, because if you all have ever called Medicare on the behalf of a beneficiary, if you've done the backdoor number, the SHIP backdoor number, you have to have name, address, date of birth, Medicare number. That's the main things, and me a contact number, please. That's the things I mainly need on there. And of course, who the who the provider is, what's the issue. That really helps. If you don't have all that, just pick me up a phone, call me or email me, and I can fill out the referral form if you don't have it handy. Okay. Any other issue? Any questions? Okay, I'm going to go through some case studies. I got some case studies here. So, case study 1. We got a beneficiary named Tom contacts the SMP because XYZ Pharmacy billed him for the Part B deductible for his diabetes supplies, even though his Medicare supplement policy would pay the deductible if the pharmacy submitted a claim for it. The pharmacy is an enrolled Part B provider but does not accept assignment. Tom called the pharmacy to explain that his Medicare supplement covers the deductible, but the manager insisted that Tom still needed to pay them directly.
No.
He paid but went to a different pharmacy for his diabetes supplies the next time. The second pharmacy billed the Medigap insurer and did not charge Tom the deductible. He calls the SMP because he thinks the XYZ Pharmacy is engaged in fraud, and he wants to report it. So what do you all think? Is this fraud, abuse, not a problem? What do y'all think?
No, because the first pharmacy did not accept assignment. Can he get reimbursed?
Yes, he can get reimbursed. He would just have to submit it to his Medigap company himself.
Okay.
So, is this Nancy?
No, this is Evelyn.
Oh, Evelyn. Sorry, Evelyn.
Yeah.
Yes, Evelyn, you are correct. This is not fraud, and it's because, or abuse, because this pharmacy does not accept assignment. A lot of beneficiaries
They also may not know it either.
Yeah, true. That's why the beneficiaries need to ask before they ever go to any provider. If they go to a doctor, anywhere, make sure that they take Medicare assignment.
Bonnie, excuse me, I've got a question. Do
Sure.
I need to wait on that?
No, go ahead.
Okay. Now, I don't have in front of me the Medigap Policy F, but if he had a Medigap policy which paid the excess Part B charge, would he then need to contact his Medigap, his insurance company that handles the Medigap policy, ask them what they recommend to do on that? Or in this case, since it was the deductible and not excess charge, would that portion of the Medigap policy even be applicable?
Well, it depends on what type of Medigap policy he has. There's, some Medigap policies.
Said F, and I didn't know if that covered that excess.
Yeah,
or not.
he has an F plan. Yeah, so if he has an F plan, the F plans do cover all the deductibles. But I mean, he would. I recommend them calling his Medigap company to see what he needs to do so he can get reimbursed. Some of them just have a form that they have to fill out that they have to send in with a copy of where they've made their payment.
Okay. Thank you.
That doesn't make any sense.
Okay. Any other questions regarding this one? Okay, I'm going to go on to the next one. Okay. Case study 2. A beneficiary named Gloria, who is enrolled in Original Medicare, reviews her MSN for a recent hospital stay. There are 2 charges for MRIs, and she only remembers having 1 MRI. She thinks the hospital might be trying to rip off Medicare. She has not yet talked to the hospital. So what do y'all think?
She needs to talk to the hospital first.
Yeah, and get the dates.
Okay.
Of the dates
MRI. And the body parts, too.
Yeah.
Because sometimes it might be a pelvis and an upper leg, but it's actually 2 different studies, although it's all done at one time.
Gotcha. Okay. Okay. That's a good thing. Yeah, what was all, what did they MRI? Yeah, because you're right. They could have done it all at the same time, but it's two different body parts, which is two different coatings. So definitely recommend her one. Yeah, you're right. Definitely I recommend her calling the hospital. So what if it wasn't two different body parts, and it wasn't 2 different days?
Check with her doctor. Verify exactly what he ordered. And it's probably, it could be duplicate billing.
Mhm.
She needs to get a full itemized bill.
I definitely recommend that. What else do y'all think?
Let the hospital know she thinks it's duplicate billing, and let them prove to her that it's not.
That's a good idea. Mhm. Definitely talk to the hospital. Now, what if she doesn't feel comfortable about talking to the hospital, and she's come to you?
Well, after I get her to sign the release of information, I can call with her present.
Okay. Yes, you can. Now, what if they don't cooperate with you?
Just tell them going to turn them over to you.
Okay.
Exactly.
That'll get their attention.
That usually does. Yeah, that usually does. Mhm. Okay, you all are correct. Good. Anything else that she might have done to help? Talk to the hospital. Talk to her doctor. Mhm.
She needs to make sure she gets the person's name that she's talking to.
Yes, definitely. I definitely recommend beneficiaries writing down notes. The date they talked to somebody, who they talked to, what they said. Take notes. I highly recommend beneficiaries do that. That way they can keep a timeline. Timelines help a whole lot. Yeah, and I highly encourage seniors, if you're in the hospital for a long period of time, get an itemized statement if you can. I know some hospitals charge for them, but it could save you some money in the long run, or Medicare some money in the long run.
And from personal experience, too, if someone is admitted to the hospital for one thing, some surgery, if that surgery ends up not being done, make sure they get a bill and look it over.
Oh, yeah,
my
definitely.
husband was admitted for a knee replacement, and some other stuff happened on, so they couldn't do it. And I got the bill, and I thought, well, for not really doing much, that's an awful big bill. So I asked for the itemized bill, and he wasn't on Medicare at the time, but it still applies. Because he was admitted for the total knee replacement, they had the prosthesis and all that in the OR ready to go. So it had already been gone through that billing process because it was stopped at the OR level when he went in for the surgery. And they billed him for that prosthesis, which was never used. And I got a hold of him. I said, I agree. That well, maybe so, but it's not in his body. We didn't bring it home with us because they had to do something else instead. And, I mean, they wrote off $4,000 or $5,000 because, again, it was inappropriately billed, but I understand why it was.
Yeah.
So, again, if you go in for one thing and something else happens, make sure you look it over.
Yeah, definitely recommend that. Okay, I've got another case study. A senior resident who wants to remain anonymous reported to you that residents at her senior apartment complex were being visited by an agent from a Medicare Advantage plan. The residents had not requested these visits, but she let the agent into her apartment because the agent said he had been sent by the doctor who see most of the residents in the housing complex. The agent proceeded to enroll the resident in a Medicare Advantage plan. The agent knew a great deal about the residents, including their Medicare numbers and their personal information. So what do y'all think?
Red flags all over the place.
Oh, yeah. Definitely red flags. And when I go out to talk to these apartment complexes, I try to talk to, like, the manager and try to encourage them to not let agents randomly go through their building.
It's not only an agent problem, it's also a doctor that should not have been giving
Yes,
that information.
exactly. There's a doctor agent, some kind of relationship going on here that needs to be investigated. Yeah. Sounds like. So, and also sounds like the doctor could have violated HIPAA, right?
Releasing personal information.
Medicare numbers and everything. That's definitely a no-no.
Right.
So where do you think we go with this one?
Definitely needs to go to be reported.
Yeah, this one's several different referrals to one to OIG and one for violating HIPAA and one for the agent, and yeah, there's several different referrals to different places in this one. So
I know they dying to get out in the back. And you out there and
Okay. So go on to case number 4. It says, David, a Medicare beneficiary duly enrolled in Medicaid, contacts SMP because he received a notice from a collection agency to pay more than $5,000 to the hospital that treated him for a serious illness 2 years ago. This was the first time anyone contacted him about a bill. He was surprised to be billed for the charges not covered by Medicare because Medicaid was supposed to cover them. In addition to the notice from the collection agency, the hospital sent him a letter saying they were going to sue him. David was distraught and overwhelmed. So what do y'all think?
Number 1, verify that he was on Medicaid 2 years ago.
Yes. Of course, Medicare does not pay for the deductible or that, 20%. So, yeah, definitely verify that he was on Medicaid then. So if he can prove that he was on Medicaid then, where does he go?
Needs to verify that they have billed Medicaid.
Okay.
Because if they haven't billed Medicaid, then they need to bill Medicaid.
Yes. Now, keep in mind, you got to also think about, was he inpatient or under observation?
Yeah, well, which goes back to your itemized bill, too.
Yes, goes back to your itemized bill. So if he was in there under observation, what is something that Medicare does not cover if you're in there under observation?
Medication?
Drugs.
Yes, that's right. Medicare does not cover his medications. I mean, surely his medication that costs $5,000, but this is just a case study.
But they can.
Yes.
But there was no observation 2 years ago.
Well, I think there was observation 2 years ago. People just didn't know about it.
No bullshit.
There's been observation for years.
I thought it just took effect this April when they had to give you a written notice.
No. Observation has been going on for a long time. They just started doing the notice because a lot of individuals did not know they were in there under observation. They thought they were inpatient.
Is there a time limit on being able to do this?
Isn't it 23 hours for 23-hour observation?
I think they have to give them 48 hours notice if they're in there under observation.
No, I mean on billing. This is 2 years
Oh, on
ago.
billing. Yes, on billing, for Medicare billing, they have a year. Unless they can,
also.
Yeah, they have a year, unless they can prove extenuating circumstances as to why they didn't bill Medicare. I mean, and it's got to be some really good circumstances. For example, fire, or something like that, as to why they did not bill Medicare.
So if you get a bill 2 years later, then it's automatically discharged, or what?
Well, the thing is, there's not a timeline for them billing the individual. There's a timeline for them submitting the claim to Medicare. Looks like they had already submitted the claim to Medicare.
So they could submit a bill to the individual any number of years later?
Yes. I don't think there's not a statute of limitations on when they can actually bill an individual.
I'd also recommend, again, that those questions be asked. This was 2 years ago. I haven't heard anything. Why am I just now being told about it?
Exactly. That's what they need to ask the hospital.
I want to clear the observation time. How long are they under observation in the hospital?
It depends. It's up to the doctor.
Okay.
Another issue.
You could be in the hospital for 3 or 4 days, and it still be listed as observation, not a full admit. And that's where the issue has come in. If someone like had a mini stroke or something and then needs to go to rehab, well, if they've been in the hospital for 3 to 4 days under observation, they don't qualify for the skilled nursing benefit. And that's what brought all of this up.
That is true.
Okay. Then observation includes, I'm sorry, my brain is just kicking in, I think. Observation includes what?
You, as the patient, you are not going to know the difference whether you have been a full admit or you're under observation. As far as services received, you are going to get the same level of care.
That
you need to listen to what the doctor and the nurses and what the people are saying. Everybody has to do their due diligence. And again, if you're the patient, it's probably not going to be your family to say, if the doctor says, well, I'm going to admit you, just to observe and watch you for a couple of days. At that point in time, then you need to say, doctor, is this a full admit? Is it outpatient observation? And more than likely, you need to push for the full admit. But it's going to be on the patient and their family at the time that they are admitted.
Because you used to observe, the patient had a stroke. And they are treating her. They are giving her everything they need to bring down the calcium levels, the enzyme levels to the heart and everything. But if somewhere in there the doctor said observation, she's in trouble. She's been there since Sunday. I actually have a case going on now. They've been there since Sunday, and I need to go ask this question if they were officially admitted, right?
Yes. Right. If they were inpatient, were they admitted as inpatient or under observation?
And I seriously don't know that question. I know we've been moved from 3 rooms. We've actually been in the 3rd room as of yesterday.
Yeah, it's probably a full admit, but my recommendation is you go back and you ask those questions.
Go ask. Yes.
Hold their feet to the fire. Now, because now they have to give you the moon notice. It should be a full admit. But that's exactly the situation that brought this up, that they didn't have to notify them and people didn't know and found out too late.
They did.
Yeah, because they keep saying they know our enzyme levels are out of order, but they can't figure out what's making them be out of order. So they're actually saying they're observing her to see, and that's what makes me leery.
Definitely,
so
yes. Go ask. Definitely, go ask.
So I don't know if that's a terminology the doctor's using or that's actually how she's admitted. So I'll find that out this afternoon.
Yeah, definitely.
Yeah.
Thank you.
You're welcome.
Okay.
Thank you, Nancy.
Question. If you want them to be admitted and the doctor's using observation, can you make the doctor change?
No.
Well, you can ask him to change it, but there is certain criteria that they have to meet to be inpatient.
Well, if it was a stroke, one would think that was the qualifications.
Not necessarily.
Oh, well.
It's more
somebody with a stroke would usually be admitted.
Yes, it has to do. I'm a retired nurse, so I've worked with the criteria that they use, and I'm not up to date on the current status. But it's severity of illness and intensity of service. It has to be
Correct.
those two things together to tip the scale to say no, that's got to be a full admit.
Yeah.
And
Right.
it sometimes
but
can
if this
get down
person's
into
got,
a very gray area.
Yeah,
yeah.
that's
But
true.
if she's got, if they're checking her enzymes, then I mean that's not from the stroke. So I mean I wouldn't think.
Well, we
But
think
it's always
the
good to ask.
level we think the level of calcium, and her calcium was like 3 times more than it should have been, and enzymes is off the chart. We think they caused the stroke.
Mhm.
A 79-year person. Patient. So
Okay.
All right.
Lonnie, to throw another wrinkle in on this case study, because this could depend upon if it's a for-profit hospital.
Yes.
For-profit will take by contract Medicare and TRICARE, but they are not obligated, nor do some have contracts with Medicaid.
Yeah.
But they should tell the individual before admitting that they do not accept the Medicaid program. The state of Indiana, many of them do not accept the Medicaid. We've got hospitals.
Really?
Profit.
Oh,
yeah.
wow.
Yeah, I won't get into that, but we have for-profit hospitals in the state of Tennessee. At one time, they were not taking the Medicaid, but they would take Medicare and TRICARE because the contracting officer told me these different contracts. So that's just as a minute sidelight to this case 4, and there's been some excellent conversations about this. The discussions have gone on about the observation and the inpatient on that. But just as a slight wrinkle to that, to this case.
Yeah, that is true. They might not take Medicaid. So they need to ask both if they take Medicare and Medicaid. Because another reason, if someone's like QMB, I've had this several times, that they'll go in there, they're with their Medicare and their QMB card, and the doctor, that won't see them because they have QMB. And they can actually do that. That's not illegal. They can say, "I'm sorry, I'm not going to take you because you have QMB." And I
thought if they took Medicare assignment, they had to take QMB.
No, they do not. Now, if they agree to take the client with the Medicare, and they know that they have QMB, then they have to take the client if they agree to that. But I've had several people call me because their doctor doesn't want to take QMB anymore, and they've had to find another doctor or things like that. So keep in mind, not everybody takes Medicare. And another thing, Advantage plan. If this gentleman was on an Advantage plan, that's a whole nother ball game, because there are hospitals out there that do not take some Advantage plans. For example, Vanderbilt does not take Blue Cross Blue Shield now.
Advantage.
Yeah, Advantage plan. So they need to make sure, a beneficiary needs to make sure before they ever go to a doctor or set up an appointment that doctor actually takes that insurance, or if they even take assignment. That's what they need to ask. And I'm trying to talk to as many beneficiaries as I can and encourage them. Ask before you set up the appointment. Make sure that they take your insurance. Ask if they take Medicare assignment. Ask if you're on an Advantage plan. Ask them specifically if they take this Advantage plan. Because they can be having to pay more out of pocket than what they need to be paying.
Lonnie?
Yes.
So if they're on an Advantage plan and they have QMB, do they have to take them?
No,
if they
not
take that
necessarily.
Advantage plan?
They don't have to.
So they can take a United Advantage plan, but they don't have to take the dual eligible special needs plan.
Yes. Now they can complain
even if they
with
have
that
Medicare and. Go ahead.
Yeah, they can actually make a complaint to that Advantage plan that their provider is refusing to take QMB.
Okay, so a provider, just because this is blowing me away. Okay, a provider that accepts Medicare assignment does not have to take somebody that has Medicare and QMB.
Yes, that is true. Trust me, the Department of Justice has explained this to us, that providers do not have to take Medicaid if they do not want to.
So what would happen? The patient would be required to pay the 20%?
If the provider knew that they had both Medicare and QMB at the time of that appointment, then the provider cannot bill them for that 20%. Now, I've had some that started doing that. I had one. She went to the doctor. The doctor saw her, did the QMB, and then at that appointment, she was like, "I'm sorry, I can't see you anymore. I'll have to refer you to a different doctor because I'm no longer going to be taking Medicaid."
Okay, so all right, let me clarify then. A doctor can take one of the Medicare, the MSPs, but not take TennCare patients that don't have Medicare. Or if you take QMB and Medicare, does that mean you have to take TennCare?
Well, QMB is a form of TennCare.
Right, but they also have Medicare. Somebody with TennCare just has TennCare, and there are a lot of providers that don't take TennCare.
Yeah. I
So
mean, it's really up to the provider. Yeah, it's pretty much all or nothing.
So they can choose.
Yes, they can.
Oh, no. So, wow. So if you take any Medicaid, you got to take TennCare to QI1.
Well, I mean,
it would just be QMB. Yeah, right.
Yeah.
So, wow.
It's either all or nothing. And that's how the Department of Justice explained it.
So what if you know of providers that take QMB but don't take TennCare patients?
Well, they might. I mean, it's really up to the provider.
Yeah, but you're saying they have to take both. I'm saying I know ones that take the QMB but not TennCare.
Well, and that's up to the provider.
But I thought it was all or nothing.
Referring to the QMB clients, it's either all or nothing. Now about the TennCare, they're specifically
so you can take
really
QMB and not take TennCare.
Yes,
that's right.
Sorry.
Okay. All right. That's where I was like, whoa. Okay.
No, I was referring to the QMB. It's either the QMB clients. It's either all or nothing. Now, whether they take the TennCare, or someone's actually Medicare and TennCare, not QMB, then I mean that's up to the provider.
Lonnie, I think also another difference. Medicaid, the TennCare rate are different. QMB would be following the Medicare rate, where the TennCare would be completely a separate negotiation.
Yes.
I think one of the differences, and I open this up, okay?
Yeah, that is true. That is true.
You're going to need a cup of coffee after this.
So, all right. Hey, we're having good discussion. I bring these up so we can have discussion and learn from each other. So, because some of you are nurses and doctors out there and pharmacists and whatnot, and that's some training I don't have. So that's why I do these case studies or try to encourage talking so we can learn from each other. So okay, so two routes for volunteers. So if you all come to, one of these cases that you don't know what to do with, one way, is contact the provider on the behalf of the beneficiary. Make sure you get the release of information signed. And it's a dual release, so it's a SHIP SMP release. I made it that way for a reason, just so, we both can use it. But, it does have my name on it, but it also has a volunteer where you can write your name in there. So if you're willing to work on that, please, I highly encourage you to work with a provider if you can. If you've tried working with a provider and haven't gotten anywhere, please submit me the referral form and the release of information. And that way, and it can be the same one that you already have signed, because it has on there and I that's why I put that on there for a reason, just so, you don't have to get another release signed. We can use the same one that you get signed. So that's, pretty much my thing. I have submitted, I've sent you all the two forms, my referral form and the release of information. Please use those. If you have any questions, please don't hesitate to call me, email me, fax me, anything, carrier pigeon, however you get it to me. The big thing is just getting me the referral so I can, actually do something with it. I've got this quote here. It says, sometimes what may seem like a simple error can actually turn out to be fraud or abuse. Or what might appear to be fraud or abuse can be a simple error. Only a review and investigation of the issue can determine if it's really fraud or not. And the investigation is not what I actually do. I do not do the investigations. I'm more like do the review. If I think it might be fraud, I go ahead and send it off to the Office of Inspector General. So, because I come across a case here recently for where a hospital has been charging beneficiaries who get cataract surgery for their eye drops that numb their eyes prior to surgery. So, and I've come off several of those cases, so I'm actually...
Is that a bundled payment?
It's supposed to be bundled in with surgery.
Okay.
But they're actually billing the beneficiaries for that medication separately, which is a no-no. So the beneficiaries are getting charged, and this is not a cheap medication. It's like $700 and something. Yeah, per eye. So think it. So,
Lonnie, what about when they're charging for the room that the surgery is done in?
Now, it depends on the facility.
Right.
Now, some facilities can actually charge for that room.
Time.
It's called a facility room fee or something.
Yeah,
I have had
so
that
they can
happen.
Do that?
Yes, they can.
Yeah, my husband had to pay like $400 just for the room.
You
And
don't need to
they
go to
had
somebody else.
patient after patient being charged this.
Yeah, some facilities can charge a facility fee. Facility use fee is what they call it.
Thank you.
Yeah, I've had that one come up before also, and had to do some research on it. So, have you all got any other questions about fraud, or if it may or may not be fraud?
You're good.
Thank you. I appreciate it.
Very informative.
I couldn't be good without you all. I said it takes us all. I appreciate it. Here's my contact information again. My toll-free number. Most of you all have my email. Of course, my email is lholloway@ucdd.org if you need me. Last month it was not pretty. I was out. Me and Sydney was out a whole lot doing a lot of trainings. So I was not in the office a whole lot. So that's why, sorry if you called me, that's why I didn't return your phone call in a timely manner. But most of the time it's easier to get in contact with me by email, because sometimes I take my computer with me so I can check my email from wherever I'm at. So that's pretty much what I've got. I'm going to see if Sydney can get back on here. Do y'all have any questions? Do y'all want to make any discussions or anything like that?
Lonnie, I'm here.
Oh, you are? Okay. I was about to text you. Tell you I'm done.
All righty, well, I'm going
to
stop the recording.
Okay.